Hello and welcome everyone to our webinar, ACR Radonc Accreditation, Everything You Need to Know. At this time, all participants are in a listen-only mode. If you have a question at any time during the presentation, please feel free to type it into the Q&A box on your screen. There will be time for questions following the presentation. Now I'd like to turn things over to your presenter, Brian Monzon, Program Manager with the ACR Radiation Oncology Practice Accreditation Program.
Hi, good afternoon, everybody. My name is Brian Monzon. I'm the Program Manager at ACR for the Radiation Oncology Program. It's called Radiation Oncology Program Practice Accreditation. I'll be saying ROPA a lot, so that will be the abbreviation for it. I also have Mr. Leonard Lucy, Senior Director and Legal Counsel for ACR, and our ROPA Committee Chair, Patrick Conway, and they'll be here to help answer questions after the webinar. So as you can see, we are now officially gold sealed here at the ACR. And I want to kind of give you a brief overview of the webinar. Basically, it's kind of like a 101 orientation of ROPA. We want to show you how to create your name, password, show you the application process, and learn the benefits and importance of accreditation. We provide you important links and contact, so if you have any questions throughout the presentation, I'll provide that for you as well. And just to let you know that we do not, Mr. Lucy and Dr. Conway and myself have no conflicts here. So basically what we need you to have to even just start with the ROPA program are a few things. If you have a PC, you have to make sure that the minimum requirement operating system is Windows XP to Windows 7. We do not support Windows 8 currently now. If you have a Mac computer, make sure you have OS X and above. Web browsers, minimum Internet Explorer 8.0 and above. We do recommend that you use Google Chrome as the preferred choice, and also Safari and Firefox. So, like I said, we are ACR Radiation Oncology Program Practice Accreditation here. We are one of many modalities at ACR, so if you're ever interested, if you have a hospital base, if you have other modalities below, we support those. So just a little brief history of, I'm going to call it e-ROPA, which is electronic. In January 2011, we launched ROPA. Everything now is electronic, so we no longer have paper. So we, as many radiation oncology fields, are trying to go from paper to paper light. As of November 12th, these were our numbers. We have currently accredited 387 accredited facilities and 144 under review. So what does it mean for facilities under review? Either they've been deferred or they're submitting their corrective action plan. Site visit has not been scheduled yet, or the final report hasn't been written yet. So as you can see, I'll just kind of start off in the beginning where you would start off to go to ACR. First, you would basically go to www.acr.org. And basically for the starting point, here are some areas where you want to access to get to the accreditation program here. Basically on the top left, you'll see a section that says Quality and Safety tab, and I'll point that out to you. You'll have a drop-down menu and you click on accreditation. If you apply for accreditation, there's another section right there. So I'll point them out to you. So Quality and Safety, or apply for accreditation, and you click on the section that says accreditation, and you select Radiation Oncology section. When you click on the Radiation Oncology section, here's some helpful hints here. You'll see the website, the link there, so you won't have to type that whole thing out. That's basically just for your reference, and I'll provide those links for you later on. But here are some useful links. So if you want to look for accredited facilities in your area, or if you find out if you're accredited, you basically click this section called Accredited Facility Search right at the top. The most important one you probably want to see is the Radiation Oncology section. I'll go over that in detail in a few minutes, which is right there. Purpose criteria and practice accreditation, practice guidelines here. These are our guidelines. These are purpose criteria. These are references that you'll need for when you go through your accreditation. So these are helpful links that you want to read thoroughly with your physician and physicist. So when you click on the Radiation Oncology section, you'll see the section here. And I'm going to go through 4 of the sections here. The program requirements, frequently asked questions, apply for accreditation, and additional resources. There's the link too as well. So the first one is the program requirement section. When you click on that icon right there, or link, it basically kind of give you a summary of what my presentation is going to be, a little bit more in detail. So it's good reading material. It will tell you from the beginning process to the end process, everything you probably need to know about the accreditation process. If you have additional questions, you could certainly contact us. The next section I want to talk about is how you apply for, or where the application's at. You click on that section right there. It says access the online accreditation. Here's the link here. It's provided for you. And I will go over that thoroughly here in the next couple of slides here. Also, the frequently asked questions section. This is a helpful area. I won't go through all the frequently asked questions, but I'll bring in a couple here. One of the top ones that we see is like, what is an FML number? FML number is basically a facility maintenance list. It's basically a number that we distinguish facilities. So like patients, they have a patient ID number. For facilities, we kind of attach that there. Right now, we haven't included this one yet. It's called Focus Studies and Outcome Studies. We have a lot of questions like that. We're trying to debate if we're going to put some examples on here, so we'll probably update that here soon. But basically what a focus study is how to fix a problem within a department, and then the outcome study is tracking your patients, their outcomes of their treatment. So an example of that is, what is the PSA of a patient that had before treatment, and then their PSA after their treatment. It's kind of an example there. And then the last part is the additional resources here. The ROP here is basically for the radiation oncologists who want to fulfill their requirements for their PQI projects for their ABR certification. This is only available for if they apply for accreditation. They use this for their PQI project. When we do the accreditation, we review 2 charts, and we fulfill that agreement for them for their PQI. So, second part right here is for if a physician or physicist want to become a surveyor, we recommend that they do that. We're in the progress of updating the application now, but it's probably a good idea if they apply for become a surveyor, because they get an idea on how the accreditation process. So it would benefit your facility for them to become a surveyor. So it makes it a little bit easier on what to expect when you apply for accreditation. And then the last one is the consultative surveys, and I will discuss that at the very end of our presentation here. So here's the home page. Here's a web link here. So when you want to create for new users, and for if you're renewing before the electronic processor, you'll need to create a user account here. And basically, we'll ask for a couple questions here. First one is that you'll need to have an email. Basically, it would be your username, and then put your first name and last name so we can distinguish who you are, and press submit. And just to let you know that we only accept one account per practice. So we're in the progress of making a system where multiple people can log on to the site, but currently we only have one person can only have account access. So once they submit the application, they'll need to receive it. They'll receive an email right here, and you'll have to confirm that's your account. So you click on that section right there, and it'll prompt you to create a password. And you'll need to have at least the minimum of 8 characteristics, which will include a letter, a number, and a special character. For example, you see here I've used welcome 1 exclamation. So that's kind of an example of what you would be using. You'll be basically on the home page here. To create an account, you want to press the View section, which I'll point out to you. Just to let you know, there's 2 parts to the application, and I'll go over this thoroughly. Basically, the first part is information about your facility, and part 2 is for your policy and procedures, if you're following the guidelines, and I'll get a little bit more information about that here in a few. So when you click on the View section, you'll open the website right here, and then you'll see a couple items that I'll point out here. You have an open and delete area. That's when you want to open up your application there, or if you want to delete it, if you want to start all over. The other section is if you want to add a new site. So if you have multiple sites, you want to click on that icon, and that's right there. And then we've had this major request here, like, hey, we need a paper application. Do you have anything available? Well, we have what we call the blank PDF, and it's right there. So, part 1 of the ROPA application. This is basically the demographics of your facility, what you do for treatments, what kind of coordinate verify system you have, treatment planning system. We want to know your how many patients you treat, what type of equipment you have, your morning warm-up, your staff, and we need to have each and every physician that treats patients and physician release forms give us permission to review the charts. On part 2, this is basically what your practice does. Which one is your main site? We need to know your policies and procedures. We need to know how you do your QA. We want to make sure that you comply with ACR practice guidelines and standards. We want to see what the chain of command is. And we also know how to have permission by your practice to come into your facility and review the practice. You also receive your payment invoice, and then we'll talk about the checklist and scheduling states here shortly. So when you submit your application, basically you'll have access to some hard copies here. So you have the invoice section, which is right here. You have, again, the blank PDF. But a new feature that we've added is that we have the application that's on paper. And then your status will change here, and I'll explain that here in a second. You can see that right there. So we've had many calls and say, where's my application? I don't know if you accepted my application. Have you received our payment? When is it going to be scheduled? Well, we have all these sections right here where they tell you where your application is at. And when you log on and you click the View section, you'll see it right in that area. So when you do a site visit, we ask that the facility prepare for our surveyors. We need to have at least 2 computers with internet access. And the reason why we ask that is because all our information on the ROPA program is on the internet. It would be helpful if you could provide 2 monitors per computer. So if you have an EMR or a record and verified system, you can have it on one screen, and then on the other screen you can have the ROPA website. Would be helpful if we had 2 staff members, preferably a dosimetrist or a physicist, to help out, basically guide through the EMR. Back in the past, we've had our surveyors pretty much go in a private room and just say, we can handle it from here. But now with the EMRs that are so complicated now these days, it's better to have someone who's familiar with your charting system and they can navigate it for our surveyors. So here are some common stopping points when you're on ROPA, and I'll explain to them each in detail here. So I can't submit the application. Well, make sure everything's filled out. The green check mark says it's filled out, but if it's in red, that means something's missing there. So make sure that when you check on your menus, that everything has a green check mark. If it's green, then it's good to go. Okay, so we talked about FML numbers. These are usually, we have a lot of problems with this when people are renewing. So for new applicants, you don't have to worry about that. ACR will assign that to you. But if you're renewing, if you click on the page 1 on the renewal section, you'll see right there, you'll click that button right there, and it'll prompt you to put an FML number right here. Well, half the time, not many people know about that, but it's located on your final report from your previous report. If you don't have access to the final report, you can give us a call, and we could provide that information for you. And when you enter that information right here where it says 1115, it'll go into the physician release form, because we've had that question too as well, like what's the FML number? And that'll auto-populate there when you enter that number in that page. Another problem that we've had is, electronic signatures. So not many people understand how to upload an electronic signature. Well, here's a couple of hints. We recommend that you try to do something on Paintbrush on your Windows machine and have them sign it and save it as a JPEG file or somewhere there, and they can upload it in this section right here. If not, you can do it the old-fashioned way. Have them write it on a piece of paper, scan it, and then save it as a JPEG file or TIFF file, and then upload it. And if the worst-case scenario, if you can't do it, you could click this section right here. It says sign on a hard copy. When you sign the hard copy, you can just upload the form. You could download the form here, have them fill it out, and then you can have them upload the, scan it, and then upload it here. Or the old-fashioned way, you could just mail it to us. You could either send it to Mike Ray, or you can send it to the Radiation Practice Accreditation Program. So when do I schedule my site survey? Well, if you apply today, don't expect to have your site survey next week, because it's just not going to happen. We would prefer you to give us 3 to 6 months, because we have other people that are scheduled to do site visits, and then also gives you some time to prepare. So if we break it down here, if you have 1 site, it's just 1 day. If you have 2 to 4 sites, it'll be 2 days. 5 to 7 sites would be 3 days, and 8 sites would be 4 days. And just remember, we don't, it won't let you schedule on Saturdays and Sundays. And if you if we happen to we're unable to schedule your site survey, then give us a call, or you can upload it, change it yourself on the ACR website. So when your facility has been assigned a site visit, we've had this question like, when do I give you the cases? Well, when you log on, you'll see a section right here. It says Data Collection. When you click on the plus button right there, a drop-down menu will come down, and you'll see census sheets. That's where you will need to upload your cases. So how many cases do we need to provide? Well, if you're a single site, we need to have at least a minimum number of cases, 25 cases. Make sure there's 5 breast patients, 5 prostate patients, 5 head and neck patients, 5 lung patients, and 5 generic patients. So generics count as probably lymphomas, whole brain, something that's not in those categories. Make sure you include the conventional IMRT, SRS, SBRT, ACR, any modality that you use in there. For a multi-site, you want to have a minimum of 25 cases as well at the main site. But for the satellite sites, we want to make sure that you have 3 cases of each of the following down here. So how does it look like when you submit the cases? Pretty straightforward here. We want you to include the patient ID number, don't include their name, and don't include their social security number. We just need a way to distinguish which ones are the charts. We need to know when their final date of treatment was. We need to know what type of treatment they did. We want to know what facility they're at. We want to know what the physician's name is and the disease site. So if it's a left lung, right breast, that'll help us distinguish what it is. And then when you save it, you want to save it here, you can cancel it. And unfortunately, you can't see the delete section. So if you accidentally put information there, you want to delete it, you press the delete button. And then when you want to add new patients, you add it right here. So the tabs are breast, prostate, head and neck, lung, generic. So I'll just kind of go through this really quickly. What are the goals for accreditation? Well, we want to provide third-party peer review. We want to evaluate and promote quality care. We want to make recommendations for improvement, and we're not here to punish you. We're here to help you out. Benefits of accreditation, I can just sum it up in a few words. That you're promoting quality and safety, and you're able to market it. As you can see, our program has grown throughout the years. We've nearly tripled our applications since 2006. We're very proud to have the VA contract. We're honored to help our veterans here. We awarded the contract in 2008, and right now we've accredited all 34 facilities, and now we're renewing all the facilities now. So why is it important for accreditation? Well, again, quality and safety. You're educating your staff why it's important to do these things. We want to be able to demonstrate the highest standards in the radiation oncology field. You want to basically show the public that you're going above and beyond, and you have recognition from your peers, from the peers. So everyone's worst part here is our fees. A single site is $9,500, and if you have multi-sites, each of those are $3,000 apiece. These all include survey, travel, and all their expenses. So one of the questions is, what do we provide for the surveyors for lunch? We don't have to do that. It's already included in your fees, so don't add the extra expense for you guys. So what qualifies as a multi-site? Well, you have one medical director that oversees the practice. You have a single physics group. All your policies and procedures are followed throughout the all the facilities, and they're within 1 hour from the main site. So we usually have a program specialist coordinate with your point of contact, whoever's your account holder, and we just want to clarify some things with the schedule. So one of the most important things is parking and where you're located, and make sure that we have all your computers and make sure the staff is available. So we try to communicate with you guys to make sure that everything is set before your site survey, so we don't do things randomly. We have a nice set schedule for you. So how long does the survey take? Typically for a single site, it usually is all day. We usually get there at opening time for you, and then we like to be out before you close. If you have a multi-site, it depends. So typically, maybe for a 2-site visit, we'll be there all day for the main site, and the next day we'll probably be there for just for a couple hours just to visit the other site. So if you have if you have 2 or 3, we try to do it in 2 days, and so forth. So what happens during the site survey? Well, we always have a radiation oncologist and a medical physicist visit your site. First thing they do is they'll sit down with your staff, mainly your chief or your medical director, chief physicist, chief therapist, dosimetrist, and nurse, and whoever wants to join in during this interview. And that usually lasts about 45 minutes to an hour. And then after that, we tour the facility to make sure everything's, we want to get an idea how you run things there. And then after the tour, the surveyors will go through all the charts, review them, and again, you have to make sure you have internet access. Then sometime after that, the physicist will try to do an interview with the chief physicist and dosimetry staff. And then throughout the day, we like to review your QA manual, CQI projects, policy and procedures, resumes throughout the day. And then at the very end, the surveyor team will kind of gather their information and meet with the same people that they met in the morning, and they'll kind of just go over some positives about your facility, and then some things that they notice, and basically it's a good time for clarification, but they won't tell you if you are accredited, deferred, or denied. They are simply data collectors, and our committee will decide the outcome of the accreditation process. So again, like I said, there's 3 categories here. There's accreditation, deferral, and denial of accreditation. The ultimate goal is to be accredited, and we usually find some type of recommendation that we have. Deferral of accreditation is basically if you were almost there, but we feel that you need some things that need to be addressed, and we give you 90 days to submit a corrective action plan. And sometimes the committee will ask for some self-assessment, so they want to have some documentation that you've been doing it. And then once the corrective action plan is approved by the committee, the facility will receive a report and then also certification of accreditation. So what's in the corrective action plan? You basically need to address the recommendations in the report, and sometimes you need to include documentation of physician superior review, physics report, and I'll explain that when we talk about the common things of deferrals. Denial of accreditation is the same thing as deferral, but we will come back. We'll recommend to come back in 6 to 9 months to make sure that you've done everything in your corrective action plan, and there is a reapplication fee of $5,000. So here are some reasons why there are facilities have been deferred. Usually it's not, they don't follow the ACR guidelines and some of the AAPM task group reports, and I'll explain to you the physician side and the physicist side. Not all of these are deal breakers, but they're common things that we've seen in deferred or denied facilities. So on the physician side, here are some of the reasons why they were deferred. And just to let you know, this is on our program requirements section, so you can find these on that section there. So, but most of them are physician reviews, lack of treatment notes, documentation is poorly done with H&P, treatment is not acceptable, portable imaging is inadequate, prescriptions are incomplete, lack of physician coverage, and sometimes if you were previously accredited and you had some corrective action plans, and some places never addressed them. And on the physics part, there's quite a few here, so I'll just kind of go through them really briefly here. It's mostly with machine calibrations here. Documentation's a key thing here. Staffing levels too. Inadequate QA and physics reviews haven't been done on a weekly basis, and the treatment as well, and poor documentation for brachytherapy. So typically when the final report comes out, on a website it says about 8 to 12 weeks. We strive to go a little bit better than that. We've been averaging about 4 to 6 weeks. The fastest that we've ever done a final report was within 2 weeks, so we're very proud of that. Back in the past, it used to take 3 months. So our turnaround since we've had the electronic version of ROPA out has been more efficient. So the final report will provide you the grade of accreditation, your staffing levels that are recommended, your recommendations for improvement for guidelines, and if you've been accredited, a link to the media kit. And I'll explain that again here. The only person that receives the report is the medical director, who's the one who signed the survey agreement. You can find out if you are accredited on the ROPA site when you log on, or the section where you have the accredited facilities search section, which I showed you in the beginning. And also in the packet, if you're accredited, you'll receive the final report, an ACR certificate, marketing kit, and some decals. Now, a consultative survey, we do provide that service. It's the same thing as accreditation, but it doesn't lead to accreditation. These are issues that are within the practice. So we've had instances where the care was great, but there were staff issues or some policy issues, and we were able to, it's kind of nice to have someone come in there and say, okay, let's take a look. We're the third person out there. We're seeing both sides. So we did a recent consultative survey not too long ago, and we concluded that the problem was that there was a physicist that was unapproachable, and it was no one really could kind of address it to him because, of course, he was unapproachable. So basically, these site surveys are 2 days. They include 3 to 4 people, which include a team of 2 physicians and probably 2 physicists, and occasionally we'll have someone, an ACR staff, join them as well. The cost is more. It's $11,500, and you also have to cover the travel and all the expenses. So what do we see for the future of ROPA? Well, we would like to come up with a scoring system so we can grade you and where the problems were at. We also want an automated final draft so the reports can go out quicker. So I think if we could, it would be nice to find out immediately, maybe within a couple of days, if you've been accredited or not. But my goal is to try to get it less than 4 weeks. We also want a quicker scheduling process. Right now, we've had the wait for scheduling usually takes about roughly about 6 months to get accredited or go through the accreditation process once you submit the application. Before it used to be a year, but with the ROPA website, it's gone to 6 months. But I think I would rather like to get that lower that number significantly. We want to be able to see trends. We want to get some metrics. Again, automated process, so it would be quicker for everybody. And we also want to get some ways of getting feedback from all users, especially from our facility. We always want to try to improve the program, so your feedback is would be very helpful. So again, here are the links here. Probably the most important one you want to start off with is with the ROPA one. I'll keep this up for a few minutes here. And then here's some contact numbers. There's my contact number. There's my email and my phone number. If you call the 800 number, down here, here's our extensions. So I'm going to leave it open here. We're going to answer some of your questions here. One of the questions here is reason for denial than deferred. Well, we have more defers versus denials. The reason for denial is multiple reasons. Number one is the facility was renewing and didn't follow their corrective action plan, and they practiced the same way they did when we first went to the facility. Physicians thought their standard of care was poorly done. There's no coverage. There's no doctors available. We've had a facility where we went there, and there was only a physician out there for one day, and he was doing stuff remotely. So those are probably big reasons why for denial of. But you have to be not even following any of the guidelines if you don't for denial purposes here. Any more questions? Is that it? Does anybody have any questions for our physician, Dr. Conway or Mr. Leonard Lucy? Separation.
Brian, this is Dr. Conway. I'm going to just chime in a bit. Again, just to follow up on your issue for denial or deferrals, it is usually a compilation of things that we've observed with practices that just results in us not accrediting them or giving a pathway to accreditation without us coming back for a second visit. Frequently it has to do with multiple cases where the care is outside what's considered standard of care treatment, inappropriate use or misuse of technology. So we've seen that. Again, not following up on corrective actions plans where there were significant deviations from the standards and guidelines. Those are some of the usual reasons for us to deny as opposed to defer.
One of the questions here is why the divergence of ACR and Astro practice accreditation? What is in store for the future of both organizations?
Brian, I'll take that question. We were really surprised by Astro withdrawing from the combined program. for whatever particular reason, I guess you would have to find out from ASTRO. As far as the ACR, the accreditation program has been in existence for 25 years, and we expect to be in existence for the next 25 years. Our numbers are up. We have more people involved with the accreditation program, both from the standpoint of staff, from physician involvement and physicist involvement. And again, we have, I think, the support of the VA that is shown by having ACR renew their accreditation of all of the VA facilities. As far as what ASTRO intends to do, we believe that they may launch their own program. However, you probably have to go to the ASTRO website and find any information about that.
The other question is, can you provide more clarification on the difference between focus studies and internal outcome studies? Dr. Conway, would you like to address that?
Yeah, a focus study is really a quality improvement study. So I'll give you a couple examples, one of which in our facility we looked at referrals to our palliative care service for non-small cell lung carcinoma patients. The reason we did that is a recent publication that showed that having patients be seen and assisted with the care of our palliative care specialists actually improves survival. And so we wanted to make sure our patients with stage 4 non-small cell lung carcinoma or small cell lung carcinoma, are they seeing palliative care physicians? So that was it was a focus study. It was a quality improvement study that resulted in a change in our process and our practice. An outcome study would be more like what is our local regional control for squamous cell carcinoma via oral pharynx. So one is more of many times getting at a quality and safety issues, the other which is traditional oncologic outcomes such as disease-free survival, overall survival, local recurrence, local control, complications. So that is the difference. Outcome studies are harder to do, I think, just in many practices, but we encourage people to do them. Focus studies or something, quality improvement studies are something that should be ongoing, and every department should have a mechanism to have those quality improvement focus studies going on, because they can result in significant improvements in patient care and in safety. Again, these can be process things. How can we shorten wait times for simulations? I mean, it can be just a variety of things. You use your staff, from therapists to dosimetrists to nursing to your people at your check-in and check-out desk. All of them can be great resources and help to come up with ideas to improve the processes of providing great care for our cancer patients.
Pretty much just to sum it up, the focus study is more for your department. What can you improve in your department? And the outcome study is mostly related to your patients. The other question is, are prescriptions requirements information able to be tied with treatment plans? Can you answer that, Dr. Conway?
Yeah. Frequently we'll see prescriptions that say per plan. I think that's an incomplete prescription. I think until someone tells me that my dosimetry is my prescription, then I guess that would be acceptable, but that's not current guidelines and standards that are out there. So my prescriptions are, comprehensive and complete, and you can look at the guidelines and standards from the ACR as to what makes a complete prescription. So it should be treatment site, orientation, energy, prescription, isodose line or depth or whatever. But I encourage you to look at the ACR guidelines, which are pretty clear for what a prescription is.
The other question is, currently we are modifying our morbidity and mortality conference. Are there guidelines what is required for M&M?
Oh, that's a good question. The guidelines are fairly loose. I think some important things are to encourage all of the staff to report morbidity and mortality, have key incidents that you would want to have an M&M review of the case, such as significant interruption in treatment, death within 2 weeks of completion of treatment, death while under treatment, unexpected hospitalizations. You can look at weight loss greater than 10% for head and neck patients. So you should come up with, within your department, what you consider M&M type cases. Usually it can be a late complications from treatment. It can be unexpected acute toxicities. Those are all things that should prompt an M&M review. M&M reviews are simply that. A non-treating physician should review the case. A careful physics review of the patient's care should be done as well. And then the outcome should be gotten back to the original treating physician and or staff that a review has been completed and the findings.
These are questions about prescription here. So in Varian prescriptions, we have trouble typing the directions of the port and prescription pointer isodose volumes. I think also to add to that, prescriptions we have trouble adding the, okay, same question here. So
I think this is a problem we come up with. I think Mosaic has a better prescription page. If there's comment section that in ARIA, I would utilize that. So I have up in front of me my Mosaic, and I have treatment technique, and I have 9-field IMRT, but in the comment section I have my beam angles listed. I have my energy, my dose specification, my total dose, my fraction dose, fractionation pattern, usually it's daily, and it's signed and by me, and I know it's a little more difficult in ARIA, but if there are places that you can utilize comments to put in additional information to meet the standard for what is a complete prescription, I would encourage you to do that. I have gotten a request to talk to the software developers, but I mean, we can show them what we consider what a complete prescription should look like, and but it's up to them, and I would encourage users to really do the same, to talk to your vendors about the difficulty with prescriptions in ARIA.
What is the difference between new patient rounds and patient rounds? So you want to answer that? Or?
Yeah, I'll answer that. For us, new patient rounds are those patients who have newly started treatment, and it's a review of the patient's care. What happened before they came to our department. In other words, surgical. If there's surgical interventions, what were the outcome of that? We discuss the indications for radiation. You should discuss the treatment plan, review the treatment plan, and total dose, fractionation scheme, etc. Kind of a weekly chart round is just a review of those patients who are under care, and any acute toxicities they're experiencing, upcoming boosts or things that need to be planned. So really what is happening during the patient's care is what I consider chart rounds.
What is the best way to do peer review for physicists and for the physician?
So we randomly, I'll tell you what we do. All of our patients, before they start a course of radiation, their dosimetry is reviewed. by a non-treating physician. So we consider that a form of peer review. We have backed peer review up into the contouring process as well to review very careful review of contours. We don't do every case. We randomly do cases or challenging cases. So that is what we consider peer review, and then also patients who have completed all therapy. Another way of doing it is I think prospective peer review is important, but also retrospective peer review can be important too, where you could randomly pull a certain number of cases for each radiation oncologist, have it reviewed by another radiation oncologist to review the entire course of care, which can include their follow-up care. So those are the elements of peer review for a physician. Physics peer review is, I would refer you to the AAPM task group about physics peer review, but basically it's similar to a physician peer review. What is the physicist doing? Is it done correctly, appropriately? That's I would refer you to the task group report on physics peer review.
Dr. Conway, what if they're a solo practice? If they don't have they only have one physician or one physicist?
Yep, it's harder to do prospective peer review in that setting. There are some facilities that have arranged networks to let that happen, but if that can't happen, then certainly that radiation oncologist must take some time off and hire a locums. That would be a perfect opportunity to do peer review of patients currently under treatment as well as patients who have completed treatment. So solo practices, I would encourage them to use locums who cover their practice to provide that peer review. And the same would be true for a physics solo practitioner.
If a site uses equipment or devices off-site, do you report that under equipment count as well, or just equipment located within the facility? That seemed like it's more like for TLDs, Dr. Conway.
We're evaluating what's occurring at the facility.
How do you document chart rounds in the patient chart?
I don't think you have to do that. Chart rounds for us is a review of what patients have been discussed that day and who attended the conference.
What I've recommended people doing is some type of documentation, like a binder or something online or something that you keep, that you could track all the patients' names there, so you know who's been done, who hasn't been done. Would you find that acceptable, Dr. Conway?
That's what we do. Yeah,
okay.
We have the patient's names, printed out, from each machine at our facility that they were presented, and we keep track of who attended.
I think we have time for a couple more questions here, so we'll probably help you with this one here, Dr. Conway. Can the prospective peer review replace the retrospective peer review?
If I had to choose one that you would do, I think prospective peer review is the most important.
Okay.
But the retrospective peer review can capture the entire course of care, what happened during treatment, after treatment, et cetera.
Dr. Conway, are you familiar with TG-142? That'd probably be more like a physics question.
Yeah, I apologize. I know some of the elements. TG142 is a significant change in introducing a lot of the imaging technologies that we've brought into radiation oncology. I defer that to my physicist. So.
Yeah, it's rather lengthy that they said, but I don't think I think it's more for diagnostic, if I recall, for a lot of that stuff. So that is where I will contact the individual with that and give them a little bit more information on that there. I think I have one more question here. Let's see. Using contractor equipment and physics to perform calibration, does the VA physicist have to perform TG51-2, or is contract just enough? Looks like if you have a second person here, so to do TG51, I'll contact our physics department, and I'll contact the individual with this question as well. I think we have one more here. The PowerPoint presentation, I can provide you with the PowerPoint presentation if you want to. We're going to upload this presentation on the website, but if you want to request a copy, I'll be happy to provide you one as well. Just email me. You can see my contacts here. We could email it to you, but it will be available on the ROPA website as well. Thank you, everyone, for attending. I really appreciate taking the time, and I look forward to working with everyone. Again, if you have any questions, please feel free to email me or contact any of my staff or myself. I hope everyone has a wonderful Thanksgiving, and look forward to hearing from you soon.